Hello, hello. Welcome back, everybody, from the break. This is it, final stretch, final panel of the day and for the summit, and it's one you do not want to miss. If anybody can hear me who is still outside, get in here. We are about to start. The next panel is on targeted pre-deployment of prevention interventions, avoiding the after effects of extreme weather. And to moderate this discussion with three highly expert panelists, I'm very pleased to introduce Colleen Connell, Managing Director for the Health Finance Coalition. Colleen has spent more than a decade with the Clinton Health Access Initiative before helping to launch Med Access and designing its critical investment pipelines. Ladies and gentlemen, please join me in welcoming to the stage Colleen and our panel.
Good afternoon, and thank you. Thank you for inviting us. We realize that we are the last panel between you and the wrap-up remarks, but we promise that this is a very interesting and optimistic panel. Before I say anything more, let me at least introduce the panelists. We have Paul Gunstensen from Evidence Action, Emma Maynard from Wellcome Trust, and Aysu Uygur from the Gates Foundation. I'll let them introduce a little bit more about their organizations and their topics in a minute, but first I want to say how I see this panel. So this panel to me is, yes, in a difficult spot, but also in a great spot, because we are kind of the culmination of a number of different themes. In the last 2 days, we've heard about how climate change is threatening the efficacy of some of our existing interventions, how it is changing the geographical presence of certain diseases, and how it's disrupting the intervention delivery. Additionally, we've talked about malaria, dengue, and cholera, how they've all been made worse. We've talked about AI and how it can drive risk analysis and early warning. We've talked about catalytic finance and private sector innovation and how that drives scale up. And as our panelists start to talk about their various interventions, you'll hear how in the face of some of these challenges that we've heard, we have reason to be optimistic and excited. Our panelists represent three different interventions that offer global health benefit while also building resilience, while also helping us to reduce the impact of climate on health for diseases like malaria and dengue and cholera. To start, I'm going to ask each of the panelists to give a quick overview of their organization and of their intervention. So we'll start with Paul, please.
Great, thanks, Colleen. My name is Paul Gunstensen. I'm the Global Water Director at Evidence Action. We're a global non-profit that takes actionable research and evidence and scales it in a very cost-effective way. Our programs are focused on global health, nutrition, and safe water. And today we reach over 200 million people each year across 9 countries in Africa and Asia. I'm here today to talk a little bit about our safe water programming, and the role that we believe it can play in mitigating the effects of climate change, but also have positive health outcomes. So water is a primary medium through which we are going to feel the impacts of climate change, both in terms of water scarcity, but also water quality. The impact on water quality will manifest itself primarily through acute events such as flooding and resulting disease outbreaks, but also through slow onset events like increasing temperatures and stressed infrastructure. The scale and devastation of flooding will increase, but that will happen likely also conversely in areas experiencing extreme heat and drought, as water runs off very hard baked ground. The resulted flooding is likely will cause destruction to infrastructure, lead to stagnant water, and that will become more contaminated by human waste and animal waste, which is, as we know, the perfect breeding ground for waterborne diseases and viruses. Interestingly, droughts and water scarcity will also have an impact on other implications. So less water in the environment means that water will become harder to treat in of itself. And ensuring sufficient water quality will increase both in importance but also complexity. We've heard a couple of times already in the last few days that Malawi is experiencing its worst cholera outbreak ever. And that is a story of climate change. It's a story of internal displacement and migration, and it's a story of low disease immunity, which is all combining to lead to the largest death rate we've seen from cholera in Malawi, 1,500 deaths to date. And as we speak, Cyclone Freddy, the third cyclone, extreme cyclone that Malawi has experienced in the last 12 months, is ravaging through the southern provinces. So what does that have to do around safe water? Well, the most common and most effective response to waterborne disease and pathogens is the treatment of drinking water through dosing of chlorine. It's a cost-effective, it's an operationally efficient way to kill most waterborne pathogens, and it stays safe. It has staying power. It stays safe for 2 to 3 days. It's endorsed by the leading institutions. WHO recommend it as an approach to improving household water quality. And in response to climate change and the increased proliferation of bacteria, the IPCC has specifically stated that chlorine should be considered a household adaptation measure. In most situations, chlorine is used proactively to disinfect water as part of normal treatment processes, but also it's often the first port of call in any emergency situation where water supply is impacted. So many of you will have heard earlier about the evidence from Professor Michael Kramer and his colleagues, which demonstrates that water treatment through chlorination can dramatically reduce all-cause child mortality. As part of the meta-analysis they conducted, the researchers analyzed some of the cost data from the Safe Water program that we run, and estimated the number of dalis averted per dollar is more than 45 times greater than the WHO's cost threshold. So it's a highly cost-effective intervention. Due to that evidence, we are now scaling up our Dispensers for Safe Water program, and we can deliver that very cost-effectively, $1.50 per year per person. And by the end of this year, we'll be delivering that to 9 million people in rural Kenya, Uganda, and Malawi. But looking forward and building off that evidence and the program's success, we've been considering, well, what next? And how do we have more impact at a greater scale with safe water? And we've started to focus on inline chlorination. This is a method of treating water within a distribution system or water sources that have a storage tank. It's a very simple device which is attached to the water storage point, and the water is cleaned as it passes through. It needs no electricity, it has no moving parts, and it provides adjustable and consistent chlorine dosing. And in most cases, it's leveraging significant existing capital investment that's happened already, but is not currently delivering the SDG target for clean water. So there's a huge opportunity for increasing cost effectiveness and delivering clean water. And in a flooding situation, inline chlorination will continue to dose because it doesn't require electricity. It's away from floodwaters on water storage, and taps and distribution points are often above the floodwaters themselves. So, we believe that inline chlorination can be both a proactive and reactive response to a climate-challenged world. It's very suited to urban and peri-urban settings, and has huge potential for the geographies where we believe will experience the most negative impacts of climate change. So,
Thanks, Paul.
Brilliant.
Emma?
Hello, everyone. Thank you for having me here today. My name is Emma Maynard. I'm Infections and Climate Research Manager from the Wellcome Trust. So at the Wellcome Trust, we're a UK-based funder with a focus on improving health for everyone by funding research, building global partnerships, and advocacy campaigns to support science. We work with people and organizations using science to solve health challenges. We fund discovery research into life, health, and well-being, and we support research to find solutions to 3 health challenges, which is mental health, infectious diseases, and climate change. So I'm going to focus on Wolbachia today, and its specific application in Aedes mosquitoes to prevent the transmission of arboviruses. So as a bit of background, the Aedes mosquitoes transmit dengue, Zika, chikungunya, and yellow fever. Dengue fever typically has a low mortality rate, however, carries a high morbidity and causes upwards of 1.9 million disability-adjusted life years per year. Dengue incidence has consistently risen and has actually seen a 30-fold increase over the past 50 years. Climate change already has and is contributing to increasing the range of the Aedes aegypti mosquito, putting 6.1 billion people at risk of dengue by 2080. So as such, we think of dengue and the other arboviruses transmitted by the Aedes mosquito as a climate-sensitive infectious disease, and thus climate change is a driver in the escalation of dengue and the others. So it's a bit more about Wolbachia. Wolbachia is a naturally occurring endosymbiotic bacteria, which was originally discovered in Drusilla flies. It was discovered that when put into Aedes mosquitoes, it prevents the transmission of arboviruses, dengue, yellow fever, Zika, and chikungunya, but also introducing cytoplasmic incompatibility, which enables Wolbachia to establish and spread throughout the mosquito population. So Wolbachia has sort of two applications, and it can be used to either replace the wild-type mosquito population, creating a more sustainable, long-lasting intervention, or to suppress the population, which requires more frequent application. For the purpose of today's discussion, I'm going to speak about Wolbachia for replacement. So you may be wondering why we need Wolbachia when we have traditional vector control tools, such as insecticides for fogging, bed nets, personal protection, environmental management, and the recently announced Takeda dengue vaccine. So traditional tools are becoming less effective. Resistance alleles have been found in the Aedes mosquito for all of the main pyrethroids relied upon, rendering them far less effective. And the link between climate change and arbovirus transmission isn't just as simple as expanding the geographical range of the vector. The changes can also affect biting behaviors, egg survival, and the speed of viral replication in the mosquito. The change in biting behavior can impact how effective personal protection measures are, and environmental and climate changes can increase an already difficult task of environmental management for Aedes aegypti mosquitoes. They can breed in a very small amount of water, about the size of a bottle cap. So the recently announced Takeda vaccine for dengue is very welcome news. However, it's not yet been widely rolled out, and currently looks like it will cost about $80 per person for LMIC users. And it remains unclear if it will be added to the next Gavi list, so it's really unclear about affordability. It's also not suitable for children under 4 who experience the highest morbidity. So I think key when we're looking at dengue and other arboviruses, there really isn't a silver bullet. What is key is having multiple tools in the toolbox to apply differently in different situations as we aim to control transmission and eventually reach elimination. And of course, we don't currently have any vaccines or treatments for Zika and chikungunya. We're currently seeing a big surge in Latin America in chikungunya, and there are concerns about a Zika resurgence as acquired immunity wanes. So as you may have gathered, I think Wolbachia is an essential intervention tool to prevent the spread and transmission of dengue and others. This is underpinned by a number of excellent and successful pilots. The randomized controlled trial carried out in Yogyakarta by the World Mosquito Programme saw a 77% reduction in dengue incidence and an 86% reduction in dengue hospitalizations in Wolbachia-treated communities. Likewise, positive results have been seen in Brazil and Colombia, with up to 64% and 97% reduction in dengue incidence, respectively. And actually, preliminary results have shown in Brazil that Wolbachia is effective against chikungunya, reducing incidence by 56%, and Zika reducing incidence by 37%. And additional trials in Australia have demonstrated the longevity of Wolbachia establishment in the population. So looking at how Wolbachia can improve climate-resilient health systems, I think we need to think of Wolbachia as a long-term preemptive intervention as opposed to reactive. Wolbachia replacement does take a bit of time, and it's really context-dependent on how long exactly that is. Releases typically take 12 to 20 weeks. Wolbachia begins to establish in the environment from around 3 months, but it can take anywhere from 40 weeks or more for Wolbachia to establish at a really high level that will be sustainable in the population. So looking at Wolbachia in the context for preparedness for extreme weather and flooding, we should preemptively be identifying at-risk countries for extreme weather and beginning the release and establishment of Wolbachia, such that as we see increasing levels of extreme weather, such as flooding, we'll be prepared and not scrabbling to implement a reactive response.
Thanks, Emma. Sue, how about SMC?
Okay, so hi everyone. I'm a strategy officer at the Gates Foundation, and I'm part of malaria and neglected tropical diseases teams. So the Gates Foundation is a private foundation. We have a range of areas of interests that are represented in our divisions. So we have global health, agriculture, global development, and these are all areas that are interlinked, but we have divisions for it at the foundation. And I'm sitting in the global health division within the malaria and neglected tropical diseases, like 2 vertical disease teams. And let me talk about malaria, because today, this session is going to be about SMC, which is the seasonal malaria chemoprevention. So at the foundation within malaria team, we have 3 strategic goals. An overarching goal of eradicating malaria within our lifetime, and doing this by reducing the burden, so bending the curve, shortening the end game, making sure we don't have a long tail of elimination, that it's short, a short road to eradication, and then the third one being combating resistance. We think our interventions should make sure that these 3 goals are addressed. And our team is divided into sub-teams that revolve around different interventions. So we have vector control, where we're working to develop innovative vector control products or improve the ones that we currently have. We have anti-malarial interventions sub-team. We have a digital sub-team that has just been established, a sub-team on delivery, and we're mostly focusing on creating innovative products, using our voice for advocacy, and we think, being a private foundation, we have the luxury to do high-risk, high-impact projects that maybe other funders may not fund. But today, I've been assigned not a very high-risk intervention at all. It's the seasonal malaria chemoprevention. It's actually a very high-efficacy existing tool that we should use where we can. Not everything has to be about innovating a new tool. SMC has been approved, endorsed by WHO in 2012, and has been used widely in many countries. It's basically a seasonal administration of antimalarials to vulnerable populations, children between ages 3 months to 59 months, during and at the beginning of the rainy season. So when malaria is seasonal and not year-round, what happens is there's a rainy season and there's a very well-defined window of peak malaria. So if you can protect your most vulnerable population during this peak malaria window, you'll have a very good, efficacious intervention to reduce the burden from malaria. It's been shown, there's at least 75% decrease in malaria incidence in children in groups that have taken the seasonal malaria chemoprevention. It's cheap, cost-effective, and also protects the most vulnerable. So it's something that we think is easily applicable to a climate disaster situation. And I'll cut it here, and I think we'll move on to other questions.
Great, thank you. So as you can see, we have 3 different interventions all sitting kind of at the nexus of climate and health. I think in a previous panel, going into COP28, we were challenged to think big. We were challenged to think about, what are the big bets that sit at this nexus? So maybe my first question to the panel will be towards Paul and Emma as newer interventions. But as you envision kind of radical scale up and you're trying to think big or describe a big bet, what does that look like for you? Paul, do you want to go first?
Yeah, happy to. I've worked for 20 years in the water sector, and this is the first time I've ever been to a health conference. And so I think, the reflection I've taken away is that the water sector is sort of over here, doing its own thing in a silo, and the potential to engage with the health sector and the climate sector to make safe water and sanitation and hygiene as well sort of foundational elements of what you're trying to achieve as well is really important. I think, to me, trying to work out ways to embed this device, this approach, this thinking into what the other sectors are thinking about is really important. And I think I was chatting to earlier some people about vaccine efficacy or deworming efficacy. But if you've got chronic diarrhea because you're drinking poor water, the efficacy of those things is reduced. And so I think the big bet, I would argue, is working collaboratively around a package of support which looks at many health outcomes, but that we bring clean water into that thinking. So,
great, thanks.
Great. Yeah, it's a great question, and sort of I think this is obviously Wellbackia is a very new and innovative intervention. So when we're looking at radical scale-up, I think beforehand there are a number of gaps that need to be addressed beforehand, and these sort of wide-reaching gaps and quite a variety, and can cover things such as funding and financing. So Wellbackia has higher upfront costs that are incurred than the current tools such as fogging. So this might require a change in thinking in how we're looking at investments. And timelines for investment also are typically beyond that of the political cycle, so it spans beyond re-election cycles, which can be difficult for garnering larger funding. So we're looking at also how can we garner private sector support. On the other side, there's the regulatory environment. So this is a new, innovative technology, and many systems are not set up to deal with it. So perhaps for radical scale-up, we need some regulatory capacity strengthening to deal with this. There are many more aspects, such as public engagement and community engagement, to support the intervention within the community. A lot of countries require pilot programs to show proof of concept, which is expensive. Developing economic evaluations to show impact and cost effectiveness. Things like developing technical and operational guidance. There are a lot of different ways you can implement Wellbackia, from eggs to releasing adult mosquitoes in many different ways. And then also manufacturing. So if we're looking at radical deployment, what's the best manufacturing setup, linking into costs? Obviously, efficiency of the scale will drive down the costs, but you're also looking at, ideally, you'd like to have mosquitoes introgressed into more local lines, but how local do you want the mosquitoes? And that will impact your manufacturing and whether you go for a more regional focus or perhaps one big hub, but there are many difficulties with this. And linking back to regulatory, there are a number of countries that don't allow for import and export of mosquitoes. So it's a very complicated ecosystem when you're looking at sort of the radical deployment. And I think, so obviously there are many gaps that need addressing. And this really requires funding and innovative solutions and bringing experts together to sort of garner support for the intervention. We're also looking at advocacy, moving away from responding to the never-ending cycle of dengue, and how do we actually shift the thinking to a long-term sustainable control of dengue and the other arboviruses.
Great. And so I know that SMC is been around for a little bit longer than these other two interventions, but as climate change changes rainy seasons, lengthens them in some places, shortens them in others, and as SMC moves out of the Sahel as well, how do you think about the package of interventions? So at the Gates Foundation, you obviously work across many aspects of malaria. How do you see SMC fitting into or with an additional package of interventions?
Yeah, so that's a very good point. Just to recap that the seasonal malaria chemoprevention is administered monthly during the rainy season, so that's typically once a month, 4-month long, 4 rounds of SMC. And, we know when countries start their rainy season, but it is true that the rainy seasons are changing, so you can start earlier, later. So there's some discussion around being able to precisely shift the SMC intervention based on what's happening with the climate. In terms of what package of interventions should be deployed together, so I will actually say something that may not be considered directly a malaria intervention, but there is a rising interest in digitizing some of these like non-routine health campaigns, like SMC, and we consider this as an intervention as well because it does impact the ability to switch all of these paper-based tracking of your SMC campaigns, like who did I give this dose to, and have just a tool, a digital tool in the hands of the healthcare workers who are administering the SMC, gives them the ability to track, to supervise when SMC is being administered door to door, for example, and then also be able to understand if all 4 doses have been administered in kids, in what proportion of kids. When we say like 80% coverage each round, are we actually targeting the same 80% of children, or is it shifting so that some kids are not getting all 4 doses, even though we thought coverage was 80%? So in a lot of the campaign-based health interventions that we have in our portfolio, we started packaging them together with digitization of these campaigns. And we find it extremely helpful to, first of all, get access to reliable data on what we did, and then be able to manage the process better next time. Because if, again, just looking at the data, if you realize you weren't reaching all the kids for all the 4 doses, this is something to do better the next time. So I would say digitization first, but typically there is also a coupling of seasonal malaria chemoprevention with some vitamin A supplements or other drugs that can be administered when healthcare workers are going door to door. One important thing about SMCs is it's not part of the routine healthcare system. It's campaign-based. So every time, you're reaching a very vulnerable population at their household. So you could use that opportunity to give them bed nets or other supplements as well.
Great, thank you. And staying with you and picking up on kind of the data theme that you mentioned. So are there opportunities to use kind of AI or early warning systems to think about when and where to deploy SMC?
Yeah, so we actually have, within the campaign digitization suite of solutions that we try to help countries with, there's a component of just geospatially locating new settlements that may not have been in your household registries in previous records. So being able to identify in the areas that I'm distributing SMC, are there new populations that I'm missing? Should I be planning towards delivering for those populations as well? And usually those new settlements will actually be sometimes the most vulnerable because maybe they will be migrants or other populations. So it's important to, through satellite images, be able to identify them, understand, based on the algorithms that we have, like how many, is this a high building, is it a lower building, like is it just a tent, how many people could be living there, and then do your planning based on that so that you don't miss anyone, because a lot of the time logistics is a very, it's what makes the campaigns work, the complicated logistics. If you can get a head start on that, then the campaign's success rate becomes much higher.
Great, thank you. I definitely want to come back to your point on vulnerable populations and migrants, but right now I want to pick up on something that Paul said in terms of integrating kind of WASH and health. So as you think about inline chlorination and as you think about radical scale up, how do you think about building on existing health systems? How do you think about building on the infrastructure that's already there or integrating into that infrastructure?
Yeah, so I think the work that's being done by the JJM mission that we heard about earlier is a really good example of that. The Indian government is investing $50 billion in infrastructure, and have asked us as Evidence Action to be a part of that process, to embed the inline chlorination device into that infrastructure. There's a whole host of infrastructure out there across Africa that's not currently delivering the SDGs, physical infrastructure. And I think there's a huge opportunity in a very low cost effective way to build off that and to make it deliver the SDGs targets for water primarily, but then these wider health benefits, which the evidence we now have from Professor Michael Kramer's work around all-cause mortality in children. So I think there's a huge opportunity. I think what's interesting about India is the political will that they're showing, the vision and the clarity of that, and then the finances to put some of that infrastructure in place. There are opportunities to piggyback off that to make it have real impact and deliver the impact that the real health outcomes that are there. So.
Thank you. And Emma, for Wolbachia, as obviously this is a pretty new approach to dengue prevention, how are you thinking about how that intervention will build on in existing systems or leverage what's there or create an opportunity to leverage off of what you're building or deploying?
Yeah, that's a great question. And I think, of course, as mentioned, it's important to integrate Wolbachia with existing tools. The sort of multiple tools in the toolbox approach is incredibly important. But I'd argue that Wolbachia actually highlights the need for a shift in the existing infrastructure around dengue and other arbovirus control. As mentioned, it seems currently there's more of a reactive approach. There's not much financing going into dengue control. And Wolbachia really requires a shift to more upfront spending, but over the long term, huge cost savings and longer term, more sustainable protection, driving down transmission hugely. So yes, in summary, I think there is a chance to build in, but more of a transformational shift is required for Wolbachia implementation.
Fantastic, thank you. And so as you think about, maybe this is to all the panelists, and Aysu, we'll start with you and come back this way. As you think about where to deploy these interventions and how to prioritize, various regions or areas, what are the metrics? How do you think about that deployment?
Yeah, so for SMC, we want to focus on high transmission malaria areas and those areas where there's a rainy season rather than a year-round malaria. I would say those two are the most important dimensions that we look at. And also the length of the rainy season and when it starts, those are also important to understand when you need to deploy them. You want to start with the rainy season so that when malaria peaks within that window, you actually have your population protected. And in terms of measuring the impact, we want to make sure that we look into the coverage levels. Did we cover our target population? Did we start with the right denominator, the target population? Did we cover them? And then did we cover them throughout the 4 doses, or did we miss a lot of the children in at least one of them? And I would also say, I think it's important, sometimes there is, families or children that consistently refuse the treatment, being able to actually understand the reasons behind those, the root causes, and be able to address it with community engagement.
Absolutely. Emma, would you like to take the same question?
Yes, of course. So actually I'm going to sort of start from a very baseline level. Actually, it's essential that we have baseline data on arbovirus transmission. And broadly speaking, we have this for Latin America and Asia. But it's something that's missing in a lot of countries in Africa. So here it's making it really difficult to implement Wolbachia and target deployments and even understand any resultant impact. And also without baseline data, it's impossible to understand how climate change is impacting arbovirus transmission and the Aedes vector. So this is one metric that I think I'm highlighting as a gap as well. Mm-hmm. And this is something that's also essential for predictive models, for understanding how climate change might impact future transmission of dengue and other arboviruses. I think sort of further in the context of a changing climate, we need good mosquito surveillance, and that's something that's relied upon when implementing the Wolbachia intervention. Of course, there's not much point in releasing Wolbachia carrying mosquitoes if there aren't any Aedes mosquitoes present in the area already. We're also bringing in surveillance of the transmission of arboviruses. So I think ideally you'd be looking for local transmission of arboviruses to inform deployment of Wolbachia. So all areas which are endemic to arboviruses should have Wolbachia deployed, but there needs to be a particular focus on countries susceptible to extreme weather events, such as flooding, which is conducive to the transmission of dengue and the other arboviruses. And this is bringing back to the preemptive approach, that it's key to combine climate and health and infectious disease data to understand what's going to happen and where to deploy. But actually, this is something that's not widely done. There's still difficulties in combining climate data with health and infectious disease data. I feel like I'm highlighting lots of gaps, but this is an important metric that isn't necessarily available yet. And then sort of going into a few more technicalities, well, with Wolbachia, unfortunately, I think we're looking at, to some extent, a limited budget. And we need to understand, I think, a bit more about sort of metrics to reliably inform which areas within a given country might see the most benefit from Wolbachia deployment and most efficiency. So there are models under development to inform this, but it's not a simple or easy task. And and I think generally speaking, there has been high effectiveness shown in urban areas, which is brilliant because that is where the Aedes aegypti mosquito is most focused. But I think we'd also want to bring in more climate data for a longer term view. So there's evidence to suggest that for one of the Wolbachia strains, WMEL, it taps out at about 34 degrees Celsius when it's consistently held for over a week. And this reduces the transmission blocking effects. So you really need to know which areas you should be deploying in. And there are other Wolbachia strains which have a higher heat tolerance. So you can switch them out, but again, this is important information and metrics to understand when you're deploying. Something interesting that we've heard as well is the combination with the tiger mosquito and what level there is in the local environment. So there's previously been deployments of Wolbachia, but then lots of tiger mosquito about. So there's just been mass fogging to get rid of this sort of pest mosquito, which has tanked the Wolbachia mosquitoes. So if you have a high level of tiger mosquito, you might want to then do more male-biased Wolbachia releases of Aedes albopictus to tank the tiger mosquito and to prevent fogging, stopping the intervention. That's all from me.
Helpful, thanks. Useful to know what's needed and what's already there. Paul, thoughts?
For us, we have kind of 4 parameters of how we think about where to deploy. So for us, it's where's the evidence of the intervention, and we've talked about that already. How cost effective is it, and can that cost effectiveness be delivered at scale? And then critically, the need. Where is the need the highest, and where can we balance out cost effectiveness with need? And by need, we think about the disease burden that's being felt by communities. And so we do sub-national level data gathering and modeling to understand, even within countries, which are the regions that are the most in need. I think the reality of something like inline chlorination is there is the scale and potential of it is huge because there's so much investment already been made in infrastructure that's not functioning. I think one of the other things that we look for in new country expansion is what are the partnerships there? What is the government's interest? Where does chlorination of water, for example, sit on the government's radar, and are they a potential partner in our ability to scale? And that's why the opportunity in India to scale through the JJM mission is so interesting, because we can play a technical assistance role as opposed to a direct implementation role. Sure. I think the last thing I would say is about sort of when to deploy. I think the argument we're making is this is a proactive response, and an investment in chlorination of water will never be a failed investment because it's needed either way. Sure. It can be a reactive response, but proactively investing now will save lives regardless. They'll save more lives in a climate-challenged world, but they'll save lives regardless.
It'll build that resilience, yeah. So as we've listened to both Paul and Emma say, they both referenced the need for community engagement and strong community engagement. And I see you talked also about community engagement. What are the lessons learned that you could offer to them to think about, or as you think about what you've tried and has worked and or has not worked in terms of community engagement?
I think not just from SMC, but in general, what we found in the malaria space, at least, is it really is important to engage the local stakeholders and decision makers from a very early stage on in designing the intervention delivery. So I would say that always being in communication with the community on the feedback. Are people accepting it? Are there concerns? What are preferences, needs? And then going back to the product development or delivery strategies and being able to update that based on the community feedback is, I think, what I would say is the most important.
Great, thank you. Let me just do one more question, and then I'll turn it over to the audience for your questions. We talked a lot about vulnerable populations throughout the last two days, and so as you think about vulnerable populations, and as you think about migrants, displaced people, climate-driven migration, how do you see these interventions interacting or benefiting various vulnerable groups? Leave it open to you to see who starts.
Okay, I can go first, very short. I think the good thing about malaria chemoprevention is that some of the other interventions that we have are based on where you're living. So like indoor residual spraying, they come and spray your home walls with insecticides so that mosquitoes die, or you have bed nets that you can put above your bed. But the chemoprevention is not based on where you live. You can be mobile and still receive the treatment. So as climate change is likely to cause more disruptions where there will be migrant populations moving and on the go, this is one thing that, it works, it's cost effective and cheap. It could be easily deployed on people that are moving. So I think it presents a viable opportunity.
Thanks.
Great. So I think, obviously, as we're probably all aware, climate change is likely to drive a huge urban migration of people. And the Aedes aegypti mosquito thrives in urban areas. So we're sort of looking at a situation where perhaps unexposed people are going into urban areas with a high arbovirus prevalence and transmission rate, potentially leading to sort of overwhelm of local hospitals in the case of a dengue outbreak. The great thing is that Wolbachia has been shown to be effective and is suited to deployment in urban areas where it's possible to get a high level of long-term Wolbachia establishment that's self-sustaining. So actually, Wolbachia could be used to preemptively deploy and actually prevent any escalation and outbreaks before they occur. So as there is urban migration from more rural areas, you don't get the exposure to dengue and other arboviruses.
Great. Well.
Yeah, I mean, I think, as we talked about earlier, that chlorination is an emergency response as well, both in terms of urban context, but also refugee camps, etc. So the immediate initial response of providing clean water can be dealt with chlorination. I mean, I think as you switch into rehabilitation and development, it gets more challenging. And I think, but I think this solution is so foundational that it can be adapted to any context, really. And so, as urban migration happens, it will put increasingly intense pressure on urban systems, and people will revert to other ways to find water. And so, finding different ways to provide chlorination to people in different contexts will be really important, and that's part of the challenge that Evidence Action has taken on to try and identify different solutions that solve the problem in rural areas, peri-urban and urban, and respond to migration as it happens. So.
Great, thanks. So let me turn it over to the audience and see what questions you have for our panelists. I think there's a...
Thank you so much. I'm called Ruth Chigozi. I'm from Uganda. Thank you, our panelists. I want to ask our panelists from Bill and Melinda Gates. Of course, SMC is one of the best interventions that is happening now. my question is, in the last couple of years, we are seeing increased morbidities in the children between about 5 to 15, 5 to 10. But the current SMC is for the under 5s. What are your thoughts on the new data that is coming up and the trends that are showing that we are seeing more incidents, more morbidities, more severe disease in the older children? Thank you. Are you considering it? What are your thoughts?
Sorry?
What are your thoughts
Yes.
in that regard? Yes.
So I think that's a very good question. And I think it can be considered to expand the SMC. Right now it is for children under 5 that's considered to be the most vulnerable. But as the setting or just the archetype of the transmission also changes in regions, we can see severe disease moving up in ages. So I think expanding SMC program is an option. Right now I don't think it's on any school-based platforms in terms of delivery. It is door-to-door in most countries, but that could be considered if we're going above age 5. Definitely an option to make it a school platform-based approach too. But I don't have yet, strong evidence on whether that's supported or not. So I think we'll need to see some research on that first, and then why not?
Great. I think I saw a hand over here, a couple hands on this side.
Yes, thank you very much for the panelists and for the conversation. I'm Oscar Seville from the Pasteur Network. I just had a question for Paul. Actually, I thought it was very interesting what you were saying, that you have all these years working in sanitation. It's the first time that you come to a health related summit. I have a water and sanitation background as well, but I haven't been working on that forever. But when I used to work on that, I'm from Panama originally. So I used to work for the National Water and Wastewater Authority. So when we talked about sanitation, it was also like separated from the health ministry. I was wondering if you've seen any transition on that. When you have your interventions, do you talk to the Ministry of Health at all? Or you just deal with the sanitation department or the authority? Thanks.
Great question. And the issue of mandates between different ministries on water and sanitation is a very complex one, particularly if you think about water in its most holistic sense. Watershed management, water resource management, they're all always very separated ministries. I think at the moment, Evidence Action talks primarily to the Ministry of Health, but I think what we're trying to do is step out into the Ministry of Water as well, and Ministry of Sanitation if it exists, and try to unite those conversations, because I think having them in silos is not wildly effective, unfortunately. I share that sort of that challenge that you've raised. So.
Again, on water, WHO and UNICEF has been promoting risk-based management approaches to make sure that water is being managed safely. And recently, we launched the Climate Resilience Water Safety Plan. No doubt, water treatment is a basic component of the water safety planning. Can you integrate, whatever you are proposing, which is basically chlorination and online chlorination? Because during the first possibly week or so, it would be suffice for the communities that are facing emergencies. But once we are in the recovery and in the other stages, we need to stabilize the system and apply the water safety management and manage the risk rather than just treating the water. And the same thing is valid, by the way, for sanitation as well.
Yeah, I think it can be integrated, and it should be. I think what we've demonstrated is a low-cost, effective way that can be deployed relatively easily. So I think it absolutely can be and should be integrated. Is the quick and easy response.
My name is Anu Kanal. I'm from Malaria No More. First, thank you for the optimism in describing solutions, that there are solutions that work, that are at the nexus of climate and health. So thank you for investing and implementing those solutions. I have a question for Emma and others in the panel to share experiences. as you think about innovative and novel solutions that are being tested, what are the barriers to scale and impact that it is desired to have, and how do we sort of create something like you described, Paul, in India, in terms of the government coming in and investing huge amounts of money in infrastructure and prioritizing it, and SMC, as you talked about, Aysu, how do we get to that scale for novel solutions that are out there and may have tremendous impact in the course of sort of disease elimination?
Great. That's a brilliant question, and I think it sort of builds on some of the questions we've spoken about on the panel. When it comes to novel mosquito control technologies, it's a huge bundle of questions that need answering for how we achieve wide-scale impact. And I think I touched on some of the issues around sort of financing and regulatory, etc. I think what it really needs is, firstly, an injection of funding and bringing together key players and stakeholders and taking perhaps a new and innovative way of thinking and approach to ensure the establishment and rolling out of Wolbachia. And part of this is advocacy and actually educating people on how it works and why it's a brilliant innovation. I think particularly when you're looking at Wolbachia, it goes against what we're told to think about, which is we're actually releasing more mosquitoes into the environment as opposed to killing them. So there's a lot of advocacy that needs to happen as well around changing the thinking.
Okay, I'll go next. So, as Emma mentioned, there's a lot of things that need to happen and a lot that could go wrong. But almost in every innovative product launch, you need a roadmap to kind of lay out what activities need to be done. Like, is it regulatory processes? Is it the evidence plan that we need to show to convince the policy makers? Is it the manufacturing and the scale up, being able to break that supply-demand, lock that usually is there? There was a talk about, I think, air conditioning in India today, and the thing about supply and demand, how it's a vicious cycle. So there is a lot of barriers along different parts of the product launch readiness journey. But what we usually don't have is funding and clearly designated owners to drive each one of these separate activities, and the accountability. So if we had a central, I'm not saying this is the solution, but how it works if you're just one company that's releasing a product is someone is managing that launch and someone's head is on the line. But what we see in global health is innovation often comes from, sometimes it comes from smaller companies that don't have the capacity or the funds or the capability, the knowledge to drive all of these different fields. And at that point, different players in the ecosystem need to work together and collaborate, and they need to make sure that there's accountability to do what's on their part to do that. So this, I think, is one of the biggest hurdles to getting a product out there in this ecosystem.
We have 3 minutes left, and I know that gentleman has had his hand up for a little bit, so can I ask, sorry to not give you the chance to reply, but in order to get one last question in.
Sorry, thanks. I just want to know about the approach regarding the integration, multisectorial, and the community with the political decision, even the assembly, NGO, private people, regarding this situation as a prevention, because there are to be an integrated policy to get a success on this matter. So I want to know what is your idea, what is your notion about this situation. Thanks.
Is there a panelist you would like to direct that to, or are you asking everybody?
No, what I mean is the approach regarding the other group of members that can help on the prevention issues, like sector, like even the decision, political decision, or NGO, those partners, even partners can collaborate on the prevention if you have some idea or suggestion about those matters regarding.
Okay. Thoughts on collaborations, partners?
Not me.
It's a good question. So how do you form coalitions and collaboration, I guess? Is that the sort of question? I mean, I think clarity on the why you would come together, clarity on a vision around what you want to achieve. Those types of initiatives are probably, can be very effective at the global level, but how do you translate that down to country level, national plan or action plans, and how do you build those coalitions? I think partnerships that are formed that lack clarity as to why they're doing it are very challenging to sustain, is my experience over years. And ones driven by funding are also very challenging. So I think, where you are aligned around a common goal or a common vision in a certain context, then that's worth investing time and effort in. But, you need to always manage partnerships, I think, and that requires resources, which is often the hardest thing to raise as well, I find. But I don't know if that answers your question, but those are sort of thoughts on how you foster collaboration.
I will add one more thing. I think it's a very hard question. The incentives need to be there for each party involved, if it's a multi-sectoral collaboration that you were talking about. I will also say there are different types of how organized you need to be that you could choose strategically. You could be very loosely connected with your partners and just have, alignment on a common vision, or you could be very tightly connected where it's a synergistic ecosystem that has the same goals, is using the same pool of money and is very, very aligned, and everyone is just doing their job. So there's a spectrum of options between those. I guess it depends on what you're working on, how aligned the incentives are, and how fragmented your funding is when you think about these coalitions.
Great. And on that, I would ask that you please join me in thanking our panelists for today and for their great interventions.